Thank you very much. Thank you for inviting me. It's a great pleasure to be here. Thank you also for coming back after the long session you had. I realize that the topic I have is not as sexy as epilepsy surgery, but it does have some appeal to me at least. So what I'm going to do is to try to give you an updated overview of the issue of the management of epilepsy in pregnancy. So this is a challenge. It's a public health challenge. If you consider that approximately 15 million women with epilepsy around the world are of childbearing age, and you can estimate that around 600,000 children are born to women with epilepsy every year. 600,000. So from a public health point of view, it's a very relevant topic. But it's a challenge also to us as the physicians of these women with epilepsy, because we need to consider, on the one hand, the risk to the fetus and the mother with maternal seizures, and on the other hand, we also need to consider the risk to the fetus, in particular, with the treatment that we are prescribing during pregnancy. So, major challenges. This is a bit difficult. What do we know about the fetal risks with uncontrolled seizures? Unfortunately, our knowledge is very incomplete there, but we have observations that guide us a bit. And it seems that in general, the risks to the fetus with uncontrolled seizures are more or less restricted to the major convulsive seizures, although there are a couple of case reports indicating that also focal seizures without generalization can cause some effect on the fetus, but I think these are the exceptions. But what we know is that a generalized tonic-clonic seizure is associated with hypoxia and acidosis, which is transferred to the fetus. We know also from monitored pregnancies that if the woman has a major seizure during delivery, you see a decline in fetal heart rate, which can last for more than half an hour, really suggesting an impact on the fetus. There have been reports in the past of a high risk of fetal loss in status epilepticus. I think that risk has been exaggerated, because if we look at the data we have from the prospective EURAP registry, where we had some 36 cases of status epilepticus when we looked at this the first time, there was only one with a fetal loss in conjunction with the status epilepticus. And then, of course, if you have a major seizure and fall, there's a risk of traumatic injury to the child. There's nothing that points in the direction that maternal seizures increase the risk for malformations in the offspring. But there's one study that indicates that frequent tonic-clonic seizures, defined as 5 or more, is associated with a poorer cognitive outcome in the child. This is a report from one retrospective study, so we really don't know if this is valid. However, in addition to these fetal risks with seizures, we need to consider the maternal risks with uncontrolled seizures. And I think too little attention has been paid to this. And this survey, which is from the UK, is, I think, a very important piece of information. What they did was to look at maternal deaths in general in UK over different time periods, as you can see here. And then they found that out of these maternal deaths, which was in the order of 1 in 10,000 pregnancies in general, 4 to 7% were in women with epilepsy, and that is about 10 times as high as you would expect if you assume that the prevalence of epilepsy in pregnancy is in the order of 0.5%. So the risk for women with epilepsy was 1 in 1,000 pregnancies approximately, compared to 1 in 10,000 pregnancies in general. It's a small absolute risk, but it's a significant increased risk. And most of the deaths were in SUDEP that you heard more about yesterday. And many of these deaths, according to reports of reviews of the case records, were due to the fact that women were, due to fear of teratogenic effects of the anti-epileptic drugs, were reducing their treatment when they realized that they were pregnant. So the bottom line is that we think that there is an indication to use anti-epileptic drug for the treatment of active epilepsy in general, and I think that indication is as strong also during pregnancy. So the goal of treatment of epilepsy in pregnancy is to prevent, in particular, major convulsive seizures, but to do that in a way by which you minimize the exposure to the fetus to drugs that are potentially teratogenic. So we're going to discuss what the teratogenic risks are and if they differ between different anti-epileptic drugs. It's now more than 50 years since we had the first signal, the first reports of malformations in children that had been exposed to anti-epileptic drugs in pregnancy. It's more than 45 years since the first case series suggesting increased risk. The question is what we have learned since then. We have learned that it's not just about major congenital malformations, it's also about the risk of an impact on intrauterine growth and on cognitive development and behavior of the exposed child. And I'm going to address all these three aspects with emphasis on major congenital malformations. But let's start with intrauterine growth retardation. This is something where the national healthcare registries that we have in the Scandinavian countries are useful because you get data from the entire population, all pregnancies, and you can correlate that to exposure to anti-epileptic drugs during pregnancy. And I will give you two examples. This first example is from Norway. Using these national databases, they looked at the risk of small for gestational age in terms of head circumference, the red symbols here. And the black symbols are small for gestational age in terms of body weight, birth weight. And what you see is that the risk is significantly increased and highest with exposure to topiramate here, both for head circumference and body weight. There is a significant increased risk also for carbamazepine, which we've known before, but in particular for topiramate here. This is a study from Denmark using the Danish National Health Registries instead, and it's just on e-publication in Epilipsia. And if you look down here, you will see that this slide is showing the risk of being born small for gestational age by different monotherapies. And here again, topiramate comes out as associated with a greater risk than expected and greater than with other monotherapies. So another signal about topiramate and intrauterine growth retardation. They looked at other things also, for instance, risk of preterm birth by exposure to anti-epileptic drugs. And they could separate anti-epileptic drugs used for women with epilepsy and women without epilepsy. And interestingly, if they just looked at women with epilepsy, they found no increased risk for preterm birth compared to those that were unexposed to anti-epileptic drug. Whereas in those that used anti-epileptic drugs for other indications, they did see an increased risk. So it shows the importance of looking not only at the drug, but also for the indication for the drug. So much about intrauterine growth retardation with the signals with topiramate. I'm now going to focus on major congenital malformations. And I'm going to start by questioning the dogma that we've been living with for many years, namely that polytherapy is associated with greater risks than monotherapy with anti-epileptic drugs. This is what we've been taught through the years. Frank Weider went through the literature a couple of years ago, and he looked at the malformation rate in polytherapy versus monotherapy in a series of publications. And you see that some publications, many of them, showed a higher risk with polytherapy compared to monotherapy. But there were also studies that reported the opposite, trends towards lower risks. The conclusion of this is that it doesn't make sense to just discuss polytherapy versus monotherapy. It depends on which drugs you combine, and that is illustrated in this graph, which is a publication from the North American Registry, looking at data from 3 different registries: the Lamotrigine Pregnancy Registry, the UK Pregnancy Registry, and the North American Pregnancy Registry. Here you have major malformations along the x-axis, and if you look at the combination of carbamazepine and lamotrigine, the risk was fairly low, whereas if carbamazepine was combined with valproate, the risk was high. Likewise, if you combine lamotrigine and valproate, the risk is high, but if lamotrigine is combined with any other anti-epileptic drug except valproate, the risk is low. So it seems that the risk with polytherapy in these studies is driven by the inclusion of valproate in the combinations. So it's not just about the number of drugs, it's about which drugs you have in your combination. That's one thing we've learned the last few years. I'm going now to malformation rates, major malformations with monotherapy exposure to different anti-epileptic drugs. And I'm going to show you data from the 3 major prospective pregnancy registries that we have, namely the North American, Europe, which is the international registry in which I'm involved, and the UK registry. And this graph shows you malformation rates along the y-axis for carbamazepine, lamotrigine, valproate, phenobarbital, and phenytoin. First thing, with carbamazepine and lamotrigine, malformation rates are fairly low. You do see a somewhat greater risk in the Europe registry, and that is because of the methodology, probably, because in Europe we follow the children up to 1 year after birth, and thereby we identify more malformations compared to the other registries that only have a time window up to 2 months after birth. But the overall impression is low and comparatively low risks in most registries for carbamazepine and lamotrigine. Here we have valproate with greater risks, and phenobarbital seem to be somewhere in between when it comes to risks. So in this graph, you only have lamotrigine among the newer generation anti-epileptic drugs, or modern anti-epileptic drugs, or whatever you would like to call them. What about the other newer generation anti-epileptic drugs? We know much less. The number of exposed in monotherapy, which you see in brackets here for the different drugs, is much lower, and this is reflected in wider confidence intervals. Again, we have the 3 major registries, and we look at levetiracetam, topiramate, gabapentin, and oxcarbazepine. And what you see, as I said, first of all, wide confidence intervals, so the precision in the estimate is not as good as when you have thousands of exposures, of course. But with levetiracetam, the indication so far, although, as I said, wide confidence interval still, is that the risk is comparatively low, in the same order as with lamotrigine and carbamazepine on the previous slide. Again, signals now with major malformations with topiramate seem to have higher rates, although you see the extremely wide confidence intervals. We know too little about gabapentin and oxcarbazepine, so we need more data on the other newer generation anti-epileptic drugs, but these are the trends that we can see at the moment in the major registries. Now, these the 3 prospective pregnancy registries that I mentioned have a lot of advantages, but they also have some limitations. And one limitation is that they have selected patient populations. They're not population-based, and that can have an influence on the results we see. They have another limitation, namely that they're mainly designed for internal comparisons. What is the risk for drug A versus drug B in that study? You don't have data on the malformation rates in the general population to compare with. So for that reason and for that purpose, again, the Scandinavian or the Nordic national healthcare registries are useful, because there you have every pregnancy included. So the data you have are representative. And this is one example. Again, this is from the Norwegian the Norwegian National Registry. and where every pregnancy is included, and the overall malformation rate in the general population of pregnancies is 2.9%. So there we have something to compare with. If you combine all anti-epileptic drugs, the malformation rate on average was 3.4 in this study. Valproate, 6.3, and in fact, if you excluded Valproate from the combined anti-epileptic drugs, there was no significant increase in the risk for the other anti-epileptic drugs in monotherapy. Again, there was a signal with topiramate, 4.2, but you can see the number of exposures, only 48, is far too small to draw conclusions, but it's a signal again. If you look at carbamazepine, in fact, in this nationwide population-based study, the malformation rate was identical to the general population. Lamotrigine also close to that. So this gives another complementary piece of information that maybe the overall risk of malformations in offspring in the general population exposed to anti-epileptic drugs is not that high that we used to think. We have Valproate as the exception. Now, it's not only about which drug, it's also about what dose of that drug, and that was clearly demonstrated in the EURAP analysis, where we looked at 4 different monotherapies, Valproate, carbamazepine, phenobarbital, and lamotrigine, at different dose categories at the time of conception, and malformation rate along the x-axis here. So you see that with each drug, Valproate, carbamazepine, phenobarbital, and lamotrigine, the malformation rate increased with increasing dose at the time of conception. And if you compare, for instance, the malformation rate with Valproate below 700 milligrams per day, it wasn't that different from the malformation rate with lamotrigine at more than 300 milligrams per day in this study. The UK Pregnancy Registry have recently published similar data looking at malformation rates with Valproate, carbamazepine, and lamotrigine by different doses. And you see also for Valproate, carbamazepine, and lamotrigine this association between dose and increased risk of malformation. Here the Valproate dose was the lowest category was up to 600 milligrams per day with a malformation rate similar to with the highest dose category of carbamazepine above 1,000 milligrams per day. So dose matters as well. The North American registry only found a dose event relationship for Valproate, and here are their data. And their cutoff was set to up to 500 milligrams per day of Valproate, with the lowest risk of malformations, which was in fact comparable then to lamotrigine. So it's about the drug, but not only about the drug, also about the dose. I'm moving on now to cognitive outcomes, whether or not exposure in utero to anti-epileptic drugs can have an adverse effect on the cognitive development of the child. And some of these data were discussed already yesterday by Christian Elger. This is, I think, by far the best study so far, the NEED study. They have published 3-year follow-up data and then the final data at 6 years in these publications. They included women in early pregnancy if they were on monotherapy with either of 4 anti-epileptic drugs, lamotrigine, Valproate, carbamazepine, or phenytoin, and the endpoint was the IQ of the child, corrected for maternal IQ at the age of 6. So this is what I'm going to show you. The IQ among those that were exposed to a high dose of Valproate, defined here as more than 1,000 milligrams per day, was lower compared to those exposed to any other treatment, including carbamazepine, lamotrigine, phenytoin, and a dose of Valproate below 1,000 milligrams per day, which was not different compared to exposure to carbamazepine or lamotrigine. So these were the outcomes of the NEED study. Again, a dose-related adverse effect of valproate. If you follow neurology, you will see a new publication with a cohort which is partly overlapping with NEEDs, which will come within a few weeks from now. I'm not free to tell you the results, but I don't think it will change the overall conclusions that we are discussing now. But keep your eyes open for that. Now, another question that has been discussed intensively is the possibility that exposure, in particular to valproate, could increase the risk of autism spectrum disorder. And this, again, was something that was analyzed using the national healthcare data, medical birth registries, etc., in Denmark. And they found that children that had been exposed to valproate had an absolute risk of an autism spectrum disorder of 4.4%. And when they combined children that had in utero been exposed to valproate versus those that had not been exposed to valproate, in this nationwide population-based study, they found that the risk of developing childhood autism was about 5-fold increased, and autism spectrum disorder increased 3-fold with exposure to valproate. For this, they did not see a dose-event relationship, but I don't think these registries are designed to look at that as good as the pregnancy registries that we are using. They found no other anti-epileptic drug to be associated with the risk of developing autism. So with this background, just a week ago, to keep you updated, the Pharmacovigilance and Risk Assessment Committee of EMA published this recommendation where they say that they are strengthening the restrictions of the use of valproate medicines due to the risk of malformations and developmental problems in children exposed to valproate in the womb. Should not be used to treat epilepsy or bipolar disorders in girls and in women who are pregnant or who can become pregnant unless other treatments are ineffective or not tolerated. So that's the new recommendation of this PRAC committee, but this is to be agreed on within the EMA before it enters the SP form. But this is the conclusion so far from the data we've seen from valproate. Now, it's not only exposure to anti-epileptic drugs that play a role for the outcome. We looked in Europe at other risk factors that could contribute to increased risk of malformations, in addition to treatment with anti-epileptic drugs. We looked at 11 different covariates, and we found that parental history of major congenital malformations was associated with a 4-fold increased risk in this multivariate analysis. So it's not just the drugs, it's probably a genetic predisposition. And I think this was also supported in 2 very recent publications from the Australian registry as well as from the UK registry. They looked at the risk of giving birth to a child with a major malformation among those that had already given birth to a child with a malformation versus those that had not. So women on anti-epileptic drugs that had a major malformation in a previous pregnancy had a 36% risk of a major malformation in a subsequent pregnancy, compared to 3% if they had not. Even stronger association if they were on valproate. In the UK study, for some reason, they combined minor anomalies and major malformations in this analysis. And they found that women that had a pregnancy outcome before with a minor malformation or a major malformation had a 10% risk for the next pregnancy. This was those that had not had a pregnancy ending in a minor anomaly or a major malformation. That was the general risk, 10%, compared to 17% if you had a pregnancy with that outcome before. And if you had 2 pregnancies with that outcome before, the risk was as high as 50%. Now, unfortunately, none of these studies analyzed the risk if the woman had changed treatment. So most of them remained on the same treatment. So we really don't know what the outcome would be if the women changed to another medication. But this also suggests that there is an individual susceptibility for pregnancy outcomes of this kind, which I think is important to keep in mind. I think we will skip that one and move over to the importance of the other aspect, namely maintain seizure control during pregnancy. We discussed the teratogenic outcomes now. What about the seizure control during pregnancy? Now, we looked in Europe at pregnancies with seizures during pregnancy, pregnancies with worsening in seizure control from early to late pregnancy, and pregnancies where the treatment changed, namely increased the dose or adding another drug was deemed necessary by the treating physician. And we looked at the 4 anti-epileptic drugs that were used in monotherapy in this analysis. And regardless of which outcome we are looking at, lamotrigine did worse than the other anti-epileptic drugs. So that's the other side of the coin. However, this is likely to a large extent to depend on the pharmacokinetic changes that take place during pregnancy. And if we are aware of those, it's likely that we can do better when it comes to seizure control. If you look at the right-hand part of this table, you will see the average changes in late pregnancy versus before pregnancy of unbound pharmacologically active concentrations. And you see that with the older generation drugs, the changes are minor, whereas with some of the newer generation drugs, we see major changes, and in particular for lamotrigine. And if we are aware of that and adjust the dosage, it's very likely, in my opinion, that we will have better outcomes in terms of seizure control during pregnancy with, for instance, lamotrigine. We can also, in the interest of time, move to breastfeeding and anti-epileptic drugs. And I tried to simplify this as much as I can by simple statements. Classifying the anti-epileptic drugs into those where we have sufficient data with or without indications of safe breastfeeding versus those where we have insufficient data or indications of that breastfeeding might not be safe in every couple. Now, sufficient data, I mean that we have published publications of at least 25, 30 or 40 mother-child pairs. And we have that for phenytoin, carbamazepine, valproate and levetiracetam, where we know that the concentrations in the breastfed infants are less than 10 to 20% of the concentrations of the same drug in the mother. For lamotrigine, we have now a lot of data. We do know that occasionally the concentration, the lamotrigine concentration in the breastfed infant can reach concentrations in the order of 25% of the maternal drug concentration. But it's uncertain if there are any adverse effects associated to that. We have recent data. We know that it does happen that adverse effects are seen with phenobarbital and ethosuximide. Limited data, no signals of adverse effects with gabapentin and topiramate, and insufficient data for these drugs. But this, I think, is important, and that is also part of the analysis of the NEED study. Namely, they followed the IQ of the children that had been exposed in utero to 4 anti-epileptic drugs in monotherapy, and they looked at the IQ in the children that had been breastfed versus those that had not been breastfed, and they saw no difference in IQ at age 3, regardless of which of the 4 drugs that they analyzed. So I come to my conclusions, and I think it's evident that exposure to anti-epileptic drugs in utero can increase the risk of malformations and also have adverse effects on cognitive outcomes and that this is in a dose-dependent manner. So what we can do to improve the outcome is to review and revise the medication, but we should do that well in advance before conception so that we can assess the effectiveness of the treatment that we are planning to prescribe to the woman when she is entering pregnancy. Select the most appropriate anti-epileptic drug, and I think it's obvious that we, whenever possible, should avoid valproate. And if that is not possible, we should in particular avoid doses above 500 milligrams per day. We should be aware of the signals with topiramate and perhaps be more cautious in using topiramate now, although the data are not really conclusive yet. And whichever drug we use, establish the lowest effective dose. Be aware of the pharmacokinetic alterations in pregnancy and that they may be important for loss of seizure control. So for drugs where we know that you can see marked changes like for lamotrigine, and I would say also levetiracetam and oxcarbazepine, it's wise to monitor drug levels and make dose adjustments. And I would say in general that we can encourage breastfeeding. And with that, I thank you for your attention.